We're on and we're started, and I just wanted to say hello and welcome to everybody. Thank you, friends, for joining us today for our January Indigenous Women's Health Talk. My name is Carly Kostishin. I'm in Thunder Bay today. We have a really beautiful snowstorm happening out here. I hope everybody is safe and warm wherever you are joining us from. I am the coordinator for the Indigenous Women's Health Talks, for the Indigenous Women's Health Program at ONWA. And today we're gathering and we're listening and learning about non-insured health benefits. And I would like to welcome Dr. Alexa today and thank her so much for sharing her knowledge on this topic. I'm certain that so many of us out there today will have questions or comments, and some very personal, that they would like to hear about and have answered today. And so I wanted to just let everybody know that there's any specific topics, even for future health talks, or specific topics around non-insured health benefits, any questions or any comments that you would like to hear about, could you please go into that chat and let us know, type in that chat box your question, and we will do our best to show Dr. Alexa and to have each one addressed. I wanted to let everybody know that before I hand the mic over to Dr. Alexa, and before this event, I stepped outside and went and put down some tobacco just to ensure that we could start off our gathering together in a good way. For those of us who are joining us for the first time, welcome. And for those who are returning for your second or your third or your 10th Indigenous Women's Health Talk, welcome back. Before we get right into it, I'll hand the mic over to Alexa very shortly, but I just wanted to touch on a couple of really small housekeeping topics. Again, that chat box is there. We're really hoping to hear from everybody out there and have a chance to answer your questions specifically. So let us know in that chat any of your questions. For those who are new to the Indigenous Women's Health Talk, we have a survey that we put out about midway through our event, definitely at the end, and ask everyone to just answer a few questions for us about how the event was for them today. And we really, really like hearing about what you would like to hear about, what topics you would like us to cover in the future. And we do collect all of those and we show them to Dr. Alexa. And so you are really in charge of helping us craft and create our future programming. So thank you for that. And again, for those who are new, every time we have a survey that is posted, and we ask you within that survey if you'd like to leave us your name and your email, and we will put your name in for a draw. We have a really lovely health basket that we will draw a name for anybody who gives us that feedback and lets us know what they thought about today's event. So again, thank you everyone for joining us. I'm also really excited to hear about this topic and this information. And so I will pass the microphone over to Dr. Alexa. Thanks again, Alexa, for being here today and helping us out with this.
Awesome. Miigwech, Carly. So I'll just start first by introducing myself for folks that don't know. So Buju, Masabekwe, Indigenous, Makwando, Dam, Bijanwabek, Saging, Nishnabek, and Donji, Nishnabekwe, and Dao. So my name is Dr. Alexa Lesperance. I am an Anishinaabe physician. I currently live and practice within Thunder Bay, Ontario, which is in the Robinson Superior Treaty. And so these Indigenous Women's Health Talk series, I think we've been doing it for over a year now, I want to say. But every month we sort of cover different health topics that are related to and or linked to Indigenous women's health and things that people want to know about. So some of that in the past has looked like menopause, traditional medicines. We did a series about sexually transmitted infections. It's really just any health topic where you want more information. So I'm going to start first just by I'm holding my Migizi Miigwan, my eagle feather, but I'll just start with a smudge and hopefully folks can feel it. And if you yourself are around somewhere where you could grab a smudge, I'll give you a second to do that. And also to grab a cup of water. I think a really important teaching that I got from Audrey, who's one of the community members that works really closely with Onwa, is really thinking about the ways that we move our nibe or our water. And so if there's an opportunity for you to get up and grab some water right now, I would highly encourage that. I'm going to give time to do that while I just light this smudge here. And feel free to join if you have that available to you. And burning gizik or cedar and sage. So hopefully you can feel the energy of that wherever you are. In whatever way that you're coming to this talk today, whether you're feeling good today, you're feeling bad, you're happy about the snow, sad about the snow. Thunder Bay has a lot of snow right now. We were just talking about the weather, but I'm very grateful for the snow when I see it because this is what it's supposed to be like right now. But I know with climate crisis, folks, we're just experiencing lots of weather extremes. So I'm also Carly also put out that same on tobacco just for our Mother Earth and the ways in which they are struggling, and also being grateful that they're regulating themselves, even if that means really inconvenient snowstorms. Okay, so I'm just going to share my slide here. Okay, can we confirm that we can see that? My tech people will confirm if that's good. So today, as Carly mentioned, it's about non-insured health benefits. And the reason why this topic came up actually had a lot to do with the fact that a lot of people don't realize what's covered or what's included, and also maybe how many barriers there are to access. So the first part of this talk is actually I want to talk about the history of NIHB, how it came to be, and what I think why it produces inequitable health incomes for Indigenous people. And then the second part of our talk will be more about the specifics, like, did you know these Flintstone vitamins are covered? Did you know, like, things that you buy over the counter are covered, and like going through how to get those things covered, and also to um, maybe encourage folks to be able to request those things because it matters. So I've introduced myself. My pronouns are she, her. For folks that don't know, I am a family doctor. So it took 10 years of schooling and I'm in my third year of practice. And so I came from a cultural background. My family is very cultural and land based. And so I was really blessed and honored to have grown up in that way and also try and how that's been brought forward in my learning journey is related to traditional medicines and trying to incorporate that. So these images are examples of things where I was in a traditional medicine camp with Kathy Bird, who is an individual from Peguis, and she teaches a lot of community members about the traditional medicines and how to harvest and how to be in relation to plants. I always remember thinking like, oh, okay, we're going to go and pick those medicines. And then she was like, nope, today we're going to sit on the ground in the bush and we're going to pray and we're going to fast. I said, oh, okay. So it was the process in which I learned things. And it's very contrasting. I think I started more formally learning about traditional medicines while I was in medical school. And I just remember coming off a pediatric rotation, seeing really sick kids and then the urgency and the fast pace of things and the way in which things are taught, maybe in medicine, which is often shame based, right? Oh, you didn't know that? Oh, like you should have known that, right? And then going to a completely different way of learning where people, gently and kindly show you things multiple times until you try it for yourself. And there's like a lot of guidance. And so you can really see the contrast in the way people are taught. And then the picture on the left hand corner. So that's myself and some of my colleagues who I did residency with. And that's when we went recently to PRIDOC, which is the Pacific Regional Indigenous Doctors Congress. That's all the Native doctors from Canada, the US, Australia, New Zealand, Hawaii, and Taiwan. And so this was when, as people were they were doing cultural sharing night, and different doctors were showing us about, of course, Maori people doing haka and all kinds of really cool things. And so we were at the front, we were really wanting to watch. So just to clarify, and I do think that this is important historical context because then it explains a lot of other things. So bear with me in terms of this little bit of history that I want to go over, um, because we have the Indian Act, right? So that's a legal document that was unilaterally signed by the Canadian government after a number of treaties had gone through, right? So there are treaties 1 to 5; those are our numbered treaties, and essentially, Native people were saying, "Hey, like you're taking up land title, and we're concerned about losing these specific rights, and we see our buffalo, our the populations are getting smaller, and so, in an attempt to try and negotiate some of this." Indigenous people actually, thought about like we should have some type of treaty because we want because the situation could worsen, right? And we want some agreements that protect our interests. And so, other Indigenous people actually how they heard about that other treaties were being made elsewhere, um, and so this was all the Indian Act came into effect essentially in response to some of the treaties that were coming out, right? So it's like, well, of course, Canada being the way that it was designed, being a settler colonial country, and trying to control Indigenous peoples, they needed to create something, right? So they created this imaginary document, which was signed. The Indian Act was signed April 12th, like 1876, which is almost 150 years ago. And in that document is where they actually declared that the federal government was exclusively responsible for the provision of all healthcare services, and that was to state recognized First Nations and Inuit people who they decided were under federal government jurisdiction. So this did not include Métis people or non-status Indians at the time. And of course, we know that the laws about who was considered Native and who had status. There's just a lot of history regarding that. But it was essentially the Indian Act. It was that original document where there was kind of an explicit um, statement about regarding health and First Nations people. And so this was because it Indian Act was Indians and lands reserved for Indian people. I say in quotes because Indian we don't use that term anymore. But just thinking this is deciding this is what we're responsible for. And so Indigenous people were, they definitely exchanged title for certain rights, right? Like the cow plows, I don't know, the $5, the annuity payment, things like that. At no point did any of the treaties actually talk about us giving over our right to govern our own healthcare. So that's really important to know because um, instead of allowing Indigenous people to self-govern, where they have their own models of care and ways of healthcare within Canada, Canada sort of took it upon itself and said, "No, this is what we're doing. We're in control of Indians and all of what they access, and therefore we're in charge of this." And this might at first seem like, "Oh, what a nice thing." Canada is doing, they're taking it upon themselves, but it was really done in a paternalistic way, meaning assuming that Native people couldn't really take care of themselves. So it wasn't this sort of let's control your health and we'll decide, what exactly, how exactly you're going to govern your health. It was not a favor to Indigenous people. It was very detrimental and intentionally devastating, right? Because then that's how things like Indian hospitals were created was through the Indian Act. Different ways that Indian agents acted with Indigenous people, hospitals being often places of segregation and experimentation, right? And so this was a way to control people's health because if people are unhealthy and well, they die. And what happens if they die? Then they're not fighting you about whose land is whose, and they're no longer becoming a problem in the settler colony that Canada was trying to create. And so around the same time that the Indian Act was being created, there was a medicine chest clause almost 4 months later, right? Because they're like, whoa, whoa, whoa. You said that you're taking over our health, but we didn't actually give up the right to self-determination. Like we didn't say that your parliament was now going to be our government. We didn't say that now like the places where we access healthcare are going to be based off of what you decide. And so the medicine chest clause, which is what this I think this talk was actually titled somewhere, something about that, the medicine chest, was just that our ancestors really had the foresight at the time to keep some of those things, the medicines that would potentially be needed for in the future. And so a medicine, I think the quote was, a medicine chest shall be kept at the house of each Indian agent for the use and benefit of the Indians at the direction of such agent. So people, native people, essentially said, okay, if you're forcing us to be controlled by Indian agents on our reserves, they better have medicines that treat us native people for the new diseases that you've brought over. And so lots of treaty experts who've looked at these things, people way smarter than me, talk about how there really aren't any references of relinquishment of jurisdiction of health, right? We did say, hey man, you guys brought over diseases, and like, we want to have access to medications based off of the diseases you've brought. But that was a unilateral decision. Indigenous people were not consulted about that. It just sort of happened, and it was a way to control. And so this is a part of why NIHB is really so inequitable today, and mainly that its roots are at are start at the creation of Canada, assimilation tactics, and then laws that were forced onto Native people. So, right, NHB was not created by us; it was not created for us. That's definitely for sure. And we didn't actually consent to giving over our health jurisdiction. That was just forcefully taken away from us. And so after 100 years later, after the Indian Act was created, right? Because the way that healthcare was being delivered was through the Indian agents. There was like churches and missionaries. Like, it was just kind of haphazardly put together, usually an afterthought. The care of Indigenous, the healthcare policy that they, or healthcare portfolio that they created, for their own intent, was just passed under like lots of different, it was called many different things, many different people within the federal government, like that was like their job, or it was just like lumped into different things. But NIHB was first started, and it was the Indian Health Policy. And that started back in 1979. So, like I say, almost 100 years later after the Indian Act. And this was a more specific ways that essentially benefits or healthcare needs were, it was an attempt by the government to have a better way of ensuring that Indigenous people had their healthcare needs met. That was the intent, right, when they created it. So NHB actually started in 2002, and that's essentially where First Nations and Inuit people, status First Nations Inuit people, were then began to be covered by certain items. And so, who is non-insured health benefits, NIHB? So this is a federally delegated health benefit program, and it's run by Indigenous Services Canada. Indigenous Services Canada used to be INAC, which is Indigenous National Affairs Canada. And then prior to that, it was known as something else, right? But it's essentially the same system, that the same groups of people and the same thought that ran residential schools, that ran Indian hospitals, are the same folks that created non-insured health benefits. So it's a branch within the federal government. And Canada created this to manage and control all funds to and from First Nations and Inuit communities. And it's important to note that a lot of these funds, because what does it cover, right? There's medications, prescription drugs, dental, there's some vision care, over-the-counter medications, there's mental health counseling, medical supplies, equipment, transportation, right? That's what non-insured health benefits cover. And what's important to note, because it's a misconception that a lot of Indigenous people face, which is that we receive free healthcare, and that how our healthcare is financed, quote unquote, is from taxpayers' dollars. And just to correct people on that, because actually all funds that are given to and come from Indigenous people's own trust funds is actually the Consolidated Revenue Fund. So in the same way, right? So when Canada was created, they said, "Yeah, this is your title. Here's the money. We're going to put it in trust for you. We're going to put it, in the banks of Canada for you, and that will accrue interest." And so you can think, if Canada was created however many years ago, and amounts that have been sitting there and accruing interest. So it's actually the interest of these accounts, in the same way that if I put $20 in an account and I did nothing with it, it would grow, right? Money on top of it would grow. And it's actually the accrued interest that gets shaved off and then distributed to Indigenous people. So, just something to consider, that the way in which we receive care is from our own money, right? From our own money that we exchanged things for. And so that's important to remember, because it addresses the misconception that, one, Native people just like have it easy, that there's like um, free healthcare, and that we're just such a burden to tax dollars and taxpayer dollars. But it's simply not, the case. That the money actually does not come from any taxpayers' dollars. In fact, we lose lots of money based off of people living within Canada, and Indigenous funds, right? If they were to pay out, and that's the thing, is the federal government does not actually give us the full amount of what we are owed in the Consolidated Revenue Fund. One, because that money that does not exist within Canada, right? Canada would not be able to afford paying out this full revenue fund. So it's within Indigenous Services Canada best interest to create these bureaucratic ways and difficulties in which we can access that money, right? And if people are unwell and they're kept unwell because they're kept on reserve, they receive lower education, they have higher mortality rates. This is the way in which the really vicious cycle that fuels into itself, right? Of keeping Native people unwell. And so non-insured health benefits, it provided last year, or from the 2022 to 2023, provided coverage for 936,000 people approximately. And it cost the total amount, of like travel, which was one of the highest costs, right? Especially Indigenous people living and being intentionally put far away from services, right? There's lots of funds that go into people traveling for their medical appointments, for imaging, whatever it is that they need for their healthcare. And so 1.89 billion towards that. And I just wanted to um, put this into context for you, that one, right, this money that is our treaty rate is accrued interest from our own money that's in the bank. The government has actually put on a very specific, uh, I guess it's not really a bylaw, but it's a way in which revenue is transferred to. So the Canadian government said, we're putting a 2% cap on how much money that we're giving to you, divided amongst yourselves, but that there is a cap on how much we're going to give to you. Which really is not in the best interest of Indigenous people, right? To have a limit, and to know, and so many Indigenous people's experiences of non-insured health benefits is so poor, and it's just really not accessible. And for reference, right, 8.9 billion. Well, that sounds so much. One, it's our own money. Two, the government spent at least 4.8 billion on tax rates for fossil fuel companies within a 12-month period. So that's what the little information on the left hand, how much does Canada give out in fossil fuel subsidies? And there's no real way to track that. That's based off of what information they do have, right? Lots of that is actually unreported by the government. So just for clarity, the thing that, because fossil fuel companies and industries make a lot of money off of exploiting Indigenous people and creating health inequities, right? Like I think of mines where there's mercury poisoning. I think of DDTs where there's areas with like lots of mills and the cancer rates, right? So just in comparison, for almost 1 million Native people who are status and or Inuit people, this is the cost versus what the government actually spent on people getting tax breaks, right? This is how they incentivize fossil fuel companies. And so there's, I think, again, this really speaks to how much is really being spent, and then the ways in which NIHB is really failing Indigenous people because it wasn't created for us or by us. And there are very specific complaints that people have about non-insured health benefits. These are just a list of some of them. So, I mean, the first, which bothers me as an Indigenous physician, is non-Indigenous people deciding what should and should not be covered despite physician recommendations. So there's lots of times where there's first line treatment. First line treatment means that when someone has a disease or an illness, there are very specific medications where they're like, this was studied and it gave the people the best outcome, right? And there's actually a lot of first line treatments that often aren't covered by non-insured health benefits. So we're usually Indigenous people are getting like second or third line, meaning like I guess it's an option for treatment, but it's not the best option. And so there's lots of times where I see specialists say, "Hey, for the best outcomes, yeah, this drug is going to cost a lot, but this is what's going to lead to the best outcome." And then those things not being covered. That's a lot of what I experience as a someone trying to get access and advocate for access to Indigenous people. Prolonged waits for necessary medical supplies and services to be funded, right? It takes so long. It's really not as simple as here's a prescription, go get this thing. There's often on the pharmacy end forms that need to be filled out. Non insured has to clarify those forms. Oh, you missed this small little thing in this form. We're sending it back to the doctor. Oh, that sits in my mailbox for however long. Oh, I didn't see this. Now I'm doing this. Then it gets sent back, right? There's so much bureaucratic process. Behind non-insured health benefits, and I do think that that's intentional in keeping our people unwell, and that's how I experience it as well, just as an Indigenous person. There's of course difficulty accessing services, and services that are often not really adequately being funded to begin with, right? So you're accessing services that already kind of suck for everyone. Outdated coverage restrictions for necessary medications, really simple things where it's just, I'm like, why isn't this covered? Or you have to have tried to do this, this, and this first. And I said, if our people were in charge of our own healthcare, um, would we actually be receiving that care within hospitals? I don't know. I don't know because we didn't get a chance to envision that for ourselves. That right was taken away from us. And people said, here, this is what you get. And that has created health inequity. I think of even things like travel arrangements that don't prioritize Indigenous women's uh, health, Indigenous women and their family safety. So there was a really um, I guess like a news report that had come out, and there was a lot of media attention around the Marlborough Hotel, which is a hotel, for example, that's located in Winnipeg, and a lot of individuals actually, who Manitoba, they would essentially come down right from the northern communities, fly into Winnipeg, and that's where they were told to board. And just the unlivable conditions. There were lots of allegations regarding that actually being a site for human trafficking, right? Lots of Indigenous women came forward about the ways in which their safety was jeopardized by being put in those really awful places, right? Places that you wouldn't want to stay and that I wouldn't want to stay. And even that, those long stays away from homes at hostels, especially when people have chronic health issues, right? Especially dialysis. If you don't have a dialysis machine on reserve or close to you, and then having to stay in a bigger city, that's time away from home, time away from land, time away from culture. And you just think about like, you don't have access to traditional foods, to care, to comfort, or to family because you're having to live away from really important health resources. There is definitely unclear instructions on how to access travel or where to go, right? People are like, "Oh, just call your band." You're like, "What?" Like, I how do I get there? Like, are you paying for my taxi? Is it a plane? Like, how am I physically getting to and from this appointment? And it's just really unclear. And they've tried to create, with non-insured health benefits now, like say for example, your health office on reserve is closed, and so you can't call the person that books hotels and stuff. They're not available. You could call the NIHB number and get access that way. But again, it's even just that, right? Having to call to ask for permission to go to a medical appointment, and then paying out of pocket for expenses and meals, travel to and from appointments. That's sometimes, community members or communities are lucky and they are able to have per diems for their community members before they travel to Toronto, for example. But oftentimes they don't, and you have to pay for that up front, and that is health inequity. I just want to stop here and answer some of these questions. So my one of them says, my family says that if I enroll in NHB program, that I am taking funding from someone that needs it more than I do. Is there any truth to this? Is there limited funding available? That's a really timely question. And the reason why I say this is because the federal government has put out a request to different organizations and different individuals. You can actually sign up for this, where they are talking about changing the Indian Act, specifically the second generation policy, which is where like certain people after, certain number of generations, they lose status. And they're talking about reinstating people to have status, which feeds into this question, right? Of I think it's important for people like whoever made up blood quantum really did us dirty, like did us Native people dirty, because that's not how we think of things. And people do have a right to access healthcare and to treaty rights. The issue is that they are talking about, and think of this, right? Indian Act been around since 1867, and they're now talking about very specifically changing that criteria. And so I think the issue is that that's being broadcast as like a good thing. Like, yeah, this is good. We want more people to have status. And I agree, because treaty rights are your treaty rights. And it was messed up that they were taken away to begin with, because that's not how we do it in our communities. The issue is that the amount that the government gives non-insured health benefits does not increase. Right? That's the thing that actually needs to increase or needs to change, because what's going to happen, and what my concern is that people are going to get the rightful status in which they deserve and which they should have had their whole life. But now, a very inequitable funding model in terms of NIHB is now going to have an influx of people, and we're going to have even less access, which is intentional. It's like very malicious, because people, there's the focus on like, well, we shouldn't even be doing blood quantum, which I completely agree with. But the issue that the government needs to focus on is actually giving us full control and ownership of our own health dollars, so that we can delegate how we want to, right? Because it's the number of people who have status will increase, but not the number, not the available funds, right? Because the government has put a cap on how much you can only get this much, and make it divided amongst yourselves. So I don't want people to feel discouraged about becoming status, in concern that you're going to be taking dollars away from someone else, because those are that's rightfully your treaty right? Like that's what we agreed to. But the issue is lobbying the government to actually give us more money then, right? Because we've had an influx, of people from like the different bills and different nations that were created that needed to be reinstated, but they reinstated that and didn't increase the funding, even though we have large pots of money that sit there, right? That are held in trust for us, that consolidated revenue fund. So there is limited funding, but I do want you to still access healthcare, especially if that's your right. But it is going to take away from people who already have a hard time accessing NIHB, because it's already really crappy to do, and it's already very limited in the things that they cover. So if there's action that you were to take, what I would advise is actually that you sign up for some of those conversations where the government is considering changing that second generation policy. And I just found out about this. I was like, what? They're changing the Indian Act? Like, and of all the things to change, right? Not that we're going to get our own government system, not that they're going to give us all of our money that's owed to us. Like, there's very specific parts within the Indian Act, right? But they specifically chose to try and change how many people have status, which then dilutes the amount of dollars that are available, which is just so messed up. So that's what we need to lobby for, is control of our own money and of our own care. But I also don't, Miss Luna, I still, I don't know. I say do it. If you're eligible for NIHB, you should be doing it. And we on the back end should really just be advocating for everyone to have that access. We have a comment here. So NIHB wouldn't cover my brace, my prescribed vitamin D, C, and B12. Yeah, so those things are covered. They are in the formulary that NIHB does cover. The issue is that we do need to get pharmacists on board with this, right? Because it's a really those things are covered just point blank. So that's incorrect that those things weren't covered, especially your vitamins. Like there's a whole bunch of different options, and we're going to go through the things that are covered. But what I do to ensure, like, one, I just like call the pharmacist and I say, hey, this is covered. Like this, and then, but a way that you can get around that is if you have the DIN code. So every type of medication has a DIN code. It's like an identifying number. And so when that's included on prescriptions, we say, like, hey, this is covered by NIHB, and maybe pharmacists are like, well, I'm not going to look that up. I don't want to look that up. No, it's just, just pay for it yourself. That's easier. Um, Either if you could even look it up for them because it's a list. The NIHB formulary is available to anyone. Um, there's like a PDF version of it and an electronic version. The issue is that the PDF and electronic don't match. So you'll look at the PDF and you'll be like, oh, that's covered. Then you go into like their actual updated system and it's not. Again, which is like a huge barrier for people where they're like, well, what is then and what isn't covered? But those things are supposed to be, it helps if on your prescription you include the DIN code, which I'll actually be presenting and giving you, and you can take pictures to be able to see um, how those because it's specific types, right? Like vitamin D if it's this specific brand but not this brand. And so but those things should be covered, and same with the brace. What I realized, because the other sometimes I don't know when I'm giving prescription for people and I say, hey, like, you really need an ankle brace, you really need someone's sprained their wrist, sprained their ankle, they need a knee brace, and that is supposed to be covered. And I know in Thunder Bay that where I send prescriptions often to Wellwise, but I myself needed a knee brace recently. And so I went and I said, oh, my nurse practitioner was like, no problem, I'll send that prescription. And it got sent. And I get there and I say, okay, I'm here to pick up the brace. And they go, okay, well, first we have to try and get a hold of NIHB and clarify if you were eligible. I was like, what? They're like, well, because you can only have one brace every 2 years. So if you've already gotten that brace somewhere in between, then you're not eligible. It's like, okay. And she's like, but I'm going to try and call. I'm like, she was really good at trying to advocate, but it was just this like, so I was like, am I not going to walk out of the store with a brace right now? Like what's happening? And so they were able to call, confirm and say, yep, Alexa is eligible for a brace. This is how much they're going to cover, $75. And the braces that were available, if I wanted one that actually would provide knee stability, the ones that I would have wanted and wanted other Native people to have were in the 200s. And so I was looking, I said, okay, this brace looks good. And they said, well, no, NHB is only going to cover $75. I said, that doesn't even cover the cost of any of your braces that you have on this right here on the shelf. And she said, I know, but like we've tried, like this is what they're going to cover. And so luckily in that moment, right, I was able to go home with a brace, but not realizing that they have to confirm that because there's weird restrictions on how often you can have a brace. I'm just like, if people have pain, give them a brace. Like, why are we, and or they lost it so you can't get another one. Just which is just ridiculous. But going to having to get confirmation if you're eligible, then the prescription, right? You have to physically bring a prescription with you. That prescription then being used, you get to pick what you want and then pay the extra of whatever else is owed. And I just think of what was exchanged for what we got. And I'm like, all this suffering from how Canada was created, and I can't even get a knee brace. And so I'm really sorry that it wasn't covered. And it was probably because you had to go through a bureaucratic process that had a lot of barriers. And not every pharmacy or place where you try to fill a prescription is actually going to try and help you because of how many barriers there are. But it is supposed to be covered. There's various, like, almost every type of brace is covered, even like casts for like, or air casts for people who have diabetic ulcers and they want to offload the pressure on your foot, right? Like those under medical, but you have to physically bring something. And then that pharmacy or that particular location has to initiate that for you. Once you're approved, then you can come pick out your thing, and then the pharmacy or in this case Wellwise will bill NIHB. But just a really awful process. I'm really sorry to hear that. Okay, let's see here. Last month, there's another, just another thought and comment. So last month, my blister packs had iron excluded. The pharmacist told me to simply buy it over the counter. He didn't understand. I get it prescribed because I can't afford to buy it. I also take very expensive drugs that there is no generic brand. I struggle to get covered for private benefits. Um, yeah, so, and this is another thing is that again, if you want access for one blister packs, you can tell them to remake it. The issue is that when pharmacists have to like redo blister packs, um, they often charge you because non-insured doesn't cover that. If things need to be specifically fixed, sometimes your pharmacists are really cool and they're like, "Oh yeah, we'll add that in or we'll get that in next time." But it is so true that it is hard to advocate at a pharmacy, and the whole point of getting prescribed iron is because it's your treaty right. Like that's what we exchanged, and so it is supposed to be covered. Iron is should your iron should be included in your blister packs. Um, and the fact that they're not, I would just push, literally stand there and be like, this needs to be included in my blister pack. Well, no, 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 just go buy that. Like, and I know it's hard to feel this way, but it's kind of relates to what we're talking about here on this side, which I just want to show folks. Which is that it can be challenging to advocate for ourselves in healthcare, especially when people are feeling sick, right? Or they're afraid of how they're going to be treated. But do your best to speak up when you can because you have patient rights. So, this is why I kind of gave the history a bit too of like, you should feel angry after hearing that. Like, what? We have all this money and they're deliberately not giving it to all, like us to actually be able to pay for things. And so just stand there and be like, nope, this needs to be covered. Nope, this needs to be covered. I know it's so hard to do. Bring someone with you if that feels really difficult. But we also need providers, right, to get on board and do some of that advocating for us. And sometimes that means I'm on the phone arguing with pharmacists, for hours, and that's really a waste of my resources as a physician. But it matters. Like, it's even if you could afford it, Teresa, it still would be the principle of, but that's your treaty right, so it should be covered. So I'm sorry to hear that, but it is, and we can go over like the DIN number, right? Because that's the thing that pharmacists need to know in order to like put it through their system. So if you have access to that number, which I will give you, you can say, "Here, it'll be really easy. Just look at this number. Just add this to the prescription. It'll go through," and they'll be like, "Okay, okay," and then they'll do that, and hopefully they can add it to your next set of blister packs. Do Inuit and Métis qualify for NIHB? That's a great question. So it's very specific Inuit communities that are covered through status. And even then, because it's, most of the NIHB claims, only 5% of them are from Inuit individuals. The rest are First Nations. And so Métis people, it really depends on your ancestry and that second generation policy that I was talking about. So you may be eligible for status if you have, I think, like there's the 6-1 and the 6-2, which is, how many relatives, how are any of your parents relatives, or are any of your parents native? Okay. Yes or no? No. Okay, well, are any of your grandparents native? Yes. Okay, how many relatives did that grandparent have that were native, right? There's like a really intense algorithm for people to actually to determine if they have status or not. But majority of Métis people with like don't. Most of them don't. And there aren't really any specific benefits that Métis people will receive outside of, you can sometimes with your ministry, like um, try and get like a, like hunting or trapping license or something like that, right? But it does not include healthcare for Métis people. And the way to check if you were eligible would be in the same way that you do status, which is like genealogy or going to non-insured or Indigenous Services Canada and just trying to apply for status. But majority of Métis people don't qualify, and it's very specific groups of Inuit communities that are included, which is very confusing. What about medical travel when optometrist is only covered twice a year? Some are required to see an optometrist once a year for eyesight monitoring. So interestingly, travel is a bit of like a different. So yes, each time if you did need to travel, and this is the thing, your optometrist would have to provide a letter saying why you need more examinations. Um, Something that I had a trouble with in regards to optometry, um, is just the advocacy bit. So yeah, you're eligible and the travel would be covered to see an optometrist. And I think, as long as someone on the other end was signing the paper that said, hey, you showed up for this appointment, the travel to an optometrist would be covered, but the cost of seeing them might not. And so that's where the optometrist would actually have to submit and try and appeal to NIHB to see if that could get covered. Um, because your travel might be covered, but the exam oftentimes won't. I have yet to have a successful case for a dentist or optometry where I've been able to get people many exams. Like there was one lady and she had a really bad tooth that we were just like really trying to preserve her bone health and her teeth. And the dentist said like this person needs to come every 2 weeks, like and NH and so having to be on the phone with NIHB and they said no, we can't cover this. We need medical reasons why. And so I said, okay, no problem. We'll get you those medical reasons why. And even once we gave those, it was still not covered. But most things regarding NIHB when you have troubles, outside of appealing many times, is just finding that support person. So I specifically try now, my healthcare providers, I try and deal with people who are going to put in that extra legwork to advocate for me. So if you are needing more appointments, ask your optometrist, hey, can you write a letter explaining why it's medically necessary for me to come this often? Travel bit is a bit easier, but that to actually get the cost, yes. Comment sad also that many places now want your money up front because NIHB is taking too long to issue money to the optometrist. Yeah. And then with the optometrist cover up front, I just think of even for my glasses, the exam was $225. I said, is that normal? Is that normal? Like, is that how much for eyeglasses the exam costs? I was like, maybe prices went up, but I agree. It is it's hard to find places now that where like NIHB is just covered, but right, that again, that's to discourage people from using it. Because if you're not using it, if you're not advocating for it, then the government doesn't need to pay that out, and they say, look, Native people aren't needing as much money. We're actually going to cut back on the 2% that we give you, right? So it's a really slippery slope of actually following through and submitting when you do things up front, right? So I think I paid up front for the optometry exam and had trouble with the letter or the receipt because it wasn't itemized. So whenever you're doing something, make sure you get an itemized receipt of what you're doing because you'll have less delays through NIHB. But it is true, lots of upfront costs where you say like, can you just charge it? And they say, no, it's going to take too long. Can I send my prescription to NHB to cover annual medical for travel? Rheumatoid prescriptions have side effects for vision and changes each year. Can I push to have an annual follow up? Yes, definitely. If you have a rheumatologic condition and you're taking medications for that, if all you have access to is to optometry, but actually I would advise like an ophthalmologist, which is different than an optometrist is a medical provider, but an ophthalmologist is like an eye surgeon and an eye specialist. So if you have that, you should definitely be seeing an ophthalmologist and you can get a referral from your doctor, someone to refer you. And yeah, that ophthalmologist might not be in your region. You might have to fly somewhere specifically for that, but they would have to cover that. That's like a very well known indication that people taking those specific meds should be getting their eyes checked every single year. So it should be covered. And you can definitely push to have annual follow up, especially for that. Okay. And so we really do need Indigenous leadership and self determination if we want to truly work towards eliminating patterns of colonial violence in healthcare systems, right? And that requires direct policy development because we need to actualize community rights and actually have self governance and cultural and spiritual development and health and wellness, right? If I was in charge of giving out the money, distributing the money for Indigenous people, I would just say, like, I would just say yes to everything. I'm like, when are people getting unnecessary? How often is it the case where people are really getting unreasonable things done, or like that prescription? Oh, we don't want to pay for that. But again, remembering how NIHB was created, this is intentional that there's bureaucratic processes, which is why we need to advocate and push for screw you guys, give us our money and we're going to do it ourselves, right? And BC is actually an example. It's the only province where non-insured health benefits does not administer their funds. They have First Nations health authorities, so they actually have it's. I mean, it's still colonial because we live in a colonial system, but it's at least governed and ran by Native people, and they decide, yep, we're going to make sure this is covered. Right? They get to allocate how it is they're spending, and it's a lot easier, right? When I'm like, can you please just cover this vaccine? Like, just cover it. Please, like, make my life easier. And like this Native person, they have this social situation going on. And so they're more receptive to those types of letters. Um, I mean, I would just fully dismantle because First Nations Health Authority still has to report in the same way that NIHB does. It's just the people making decisions are actually people in the community. So it's done a little bit better. We have a comment here. My chiropractor said that they always have issues for patient coverage through NIHB. NIHB does not cover chiropractic care. They do, and same with like if you wanted like physiotherapy, massage therapy, those things aren't covered through non-insured health benefits. That would likely be what they're trying to do is if you have a policy, they're probably doing your work policy, seeing if status will cover any amount of it, and the issue is that they don't. So and there's no such thing really because all chiropractors are usually fee for service. They're not really built into healthcare models, right? Because it's like, well, how could you get physiotherapy? Well, you wouldn't be able to pay for it privately. You'd have to go through like a hospital where it's covered, right? Which long wait times, people's disease and illness is getting better. But from my understanding, chiropractic care actually isn't covered at all by non-insured health benefits. Okay. We are at 3 o'clock. So what I'm going to do, and we're doing this until 4. So what I'm going to do is we'll stop here, allow for people to just take a little bit of a quick break. Please get up, walk around, drink some water, do what you need to do. And we'll come back in like 5. We'll come back. It's 2:52. So we'll come back right at 3. And the rest of the talk will be going over specific things that are covered, but I'll give people a chance to more comments if you want me to read them out or more questions. But the resounding message that I want people to really take from, if there's nothing that you take, is that it is your treaty rate to have these things covered. It's more work for you, and um, to try and find those specific numbers so that we can give them to pharmacists so that it goes through quicker. But they are available. I'm going to show them to you so that you can have access to them. But you can also look them up, right? And sometimes what I will do, I joke, I kid you not, there are times where I'll pull up the NIHB. I'll be like, oh, they're like, that's not covered, and I'm like, I just have it like it's just like a thing that's always on my phone now where I'll stand there and I'll say, yes, it is. I'm gonna show you the NIHB formulary. Here you go. And I'll show it to them and I'll be like, it's covered. And they're like, oh, okay, and then they go and look and then they see the number, they type it in. Okay, then it's good. So my advice to people is that when you go to the pharmacy is to pull up the NIHB formulary on your phone. And if they say it's not covered, I literally just hand them my phone and I'm like, you have access to this too on your computer as a pharmacist. But if what it takes is me having it available and ready to go, it is a lot of extra burden and it's a lot of time and energy, right? Like people don't want to have to go to the pharmacy or pick up things and know that it's going to be a fight, right? Because then people are just like, fine, I'll just pay for it, even though they shouldn't be, even though it's covered. And so a treaty right is a treaty right. We have given things in exchange. The government has really like cheaped out on what they actually owe us, hence why you're getting these large like annuity payouts for the decades and centuries that they've been really not even following the treaties, but get it covered even by principle. I think it's always important to push and know that I'm telling you that it's okay to do that. And you might be labeled as a problem person. I know that when I go to the pharmacy, I'm totally a problem patient when I go there. Like they just at this point now, but now they know when I'm like, this is covered. And they'll be like, okay. So you just have to do your best, but keep fighting for those things. And remember, it's your treaty right if you have a status card, so you should push for it. Okay, so let's take a break. We'll come back at 3, and then we'll go through some specific medications that I want you to know are covered. So, we had some questions over the break about where to actually access this. And so I just want to show people how to get there. So, you pull up Google and you type NIHB Express Scripts because that's their main portal and their platform where lots of medications, that's where the most up to date list is held. So you Google that, and the link will be posted for people to look along with me. But it's this here, Express Scripts Canada. Okay. And so you can make an account. I have an account. Providers can enroll to have an account. And this is where you submit client reimbursements as well. So if you just click on there, and it'll pull up the list. You might have options where, you get to look at the PDF list, which looks like this. And I don't recommend it because this is from 2020 and it's not up to date. But if this is an easier way to scroll through, this is often how I kind of get like a little um, teaser of if something's covered, and I'll go here first and then I'll confirm here. Okay, but so you come to Express Scripts Canada, you go to English, and then are you a provider or a client? I'm a client. Great. Okay. So I want to know what kind of benefits I have. So there's different policies, benefit lists and guides, resources, and then there's a portal for the to be reimbursed for things. So I go to benefit lists and guides, and I want to know about, let's go vision care. You're opening an external link. Okay. Okay. So then we can look here. There's vision care regional fee guides. And so this is how it would be covered, right? And the frequency of which it could be covered. And so vision care benefits are covered in accordance with NIHB policies. Providers must obtain prior approval from the NIHB office in the province or territory where the service is provided for a general eye exam outside of frequency guidelines. Right. So there was a question of like, well, I need to see I need to see an optometrist or an eye doctor more frequently. So you would submit a prior approval. As a patient, you're not really able to do that. It's actually a provider that needs to do it on your behalf and then fax it to the regional office to talk about like, okay, well, how often can I get an eye exam? Well, if you're under 18, you get one. If you are this age, right, you get one every 2 calendar years. Okay, but what about if you're over this age on your 65th birthday? Okay, well, then you're back to one per calendar year. You don't have to wait every 2 years, right? Follow up exams reviewed case by case. And so this is essentially what you would do. So unfortunately, patients cannot initiate prior approval requests. It has to come from a pharmacy or a provider. But just going back to this NHB, okay, there's vision care, but this is what I want to know is pharmacy, because this is where you can find all drug benefits lists. And it's kind of confusing because there's item name and there's chemical name, but say you just wanted to know like, okay, I'm going to type in vitamin. What shows up here? Now, here's all of the things that are covered, right? Let's say that I want vitamin B6. And this is specifically what I want. Okay, there's the different manufacturers of this, but I want B6. There's many options, right? There's that I could pick through, but this is the DIN code, meaning this is the information I need in order to ensure it's this specific drug, because NIHB will only cover this specific brand of this specific number, right? If I tried to do another vitamin B6 that wasn't on this list and the DIN code didn't match up, then it wouldn't be covered. But I say, nope, I can see here on this little page here that that's covered, vitamin B6. So how do I know? Okay, well, I can see that in BC, Prince Edward Island, Ontario, Alberta, Manitoba, it's an open benefit, right? So every province, it tells you if it is an open benefit. Open benefit means that like a prescription could be sent by a nurse practitioner, midwife, physician, whoever it is you're seeing, that can be sent to the pharmacy. And the pharmacy doesn't need to get special approval from NIHB. They can just go ahead and send the prescription. And there's no limit on, like, oh, you can only have this many pills over this time frame, right? You can kind of just get it as needed, how often you need it. So it is an open benefit for everyone, right? And to make sure that I get the drug that's actually covered, I would say make sure it has this number. and I want this specific dose, and then that's how it would be covered. Another example, say like, yeah, but you can see all the vitamin A gel. This is actually a not a vitamin that you would take. It's for acne. But for example, let's think of another, um, like reactant, which I'm going to go over. Right. So I type in reactant. I want to know the item name. Okay, this is what's available to me. So I could get a 20 milligram tab. I could get a 10 milligram tab. I could get drops. Right? This is what 5 milligrams per 5 milliliters means. Okay, well, say that I don't want to give my kid reactin because they're super allergic to everything. Okay, so I can go to view details and I can see that it's an open benefit in every province and territory. And we're in Ontario, or maybe you're in New Brunswick, and you can see it's an open benefit. Great. But it has to be this specific DIN, this specific product. That's how you know NIHB will cover it, because it's on this is the most up-to-date list that they keep. Okay. Um, and so let me go back here now. I'm going to stop share. I hope that answers people's questions. And I'm just going to share my PowerPoint again. Mhm. Okay. Oh, okay, great. The next thing that we're talking about is actually vitamins. So say that this is specifically, so vitamins that are covered: vitamin D, Flintstones with iron. There's also I remember as a kid I used to love taking those are covered, and different variations of them are prenatal vitamins, right? So this is Materna, and technically in this case you would see that this is an open benefit, but there's specific coverage criteria. So this meaning that if you want these particular vitamins, you have to be of childbearing age, 12 to 50 years old. So, say you're 11 and you wanted to take this. No. Say you were 51 and you wanted this particular prenatal vitamin. Prenatal vitamins actually have a bunch of things in them. It's not really specific to pregnancy. It just happens to have folic acid, which is one of the main things you need so that babies don't develop neural tube defects. That's the main ingredient in, and iron, because pregnant people, their iron gets really reduced over time. So prenatal vitamins, multivitamins, have a mixture of a bunch of things, but you don't actually need to be pregnant in order to get this. You just need to be of childbearing age, 12 to 50, regardless if you're pregnant. Same with multivitamins for women, right? So this is a product that a lot of people like to use. Centrum for women, right? It has more calcium, and magnesium and vitamin D. That's really important for women specifically, because as you grow older and you have less estrogen in your body, you're more at risk for developing osteoporosis and then fractures. And so you want to keep up with calcium and vitamin D. Okay, great. Well, you can actually, so you don't have to pay for this. This is covered, right? This is actually covered. And so these are examples of the DIN number. And you'd say, if it wasn't on the prescription, you would stand there at the pharmacy and they say, oh, it's going to be $22. And you would say, oh, actually, no, it's covered. I want this specific medication right here. And this is the DIN number. And this is how I know it's covered. So you can physically show that to providers and to pharmacies. The next slide we have is about some other vitamins that are covered that I want people to know about, because you might not already know this. So calcium, vitamin B12, vitamin E, vitamin C, vitamin A, and vitamin B6. So again, we could do the same process where we go to Express Scripts Canada, we type in the medication. It'll auto-populate and tell us what is actually covered, but you don't actually have to pay out of pocket for these things. They are covered. Same with iron supplements, and in different forms, right? So oftentimes, right, of course, prescriptions. So, and this requires a prescription, right? So like, I couldn't just show up to the pharmacy and be like, hey, can I get vitamin D? Or, hey, I want to just take this Flintstones with iron vitamins off the shelf, right? You need a prescription first, and that's the bureaucratic part that takes a lot of time and can sometimes be a really big nuisance, right? Because you're like, oh, I don't want to wait for, I don't want to have to, because seeing a provider can take a long time. So people just buy it over the counter, which is okay, but you don't have to, nor do I agree that you should. I think it is worth, but then it provides it, then it causes delay. And then that's the perpetual cycle of NIHB. These things are covered: calcium, vitamin B12, vitamin E, B6, A, and C. And then iron supplements, right? So there are iron supplements people can take, but there's also over the counter stuff where you're like, well, actually, the tab really isn't going to work for me. I want to get drops, right? So Enfamil Ferrensol, which is a liquid serum and like an oral solution, right? Say maybe you don't want to take pills because it hurts your stomach, or you have a kid and they need iron. This very specific product has this DIN number, and if you included this on the prescription, you would get this covered. Same with for babies, right? So this is PDFer, which is also an iron supplement. If you have this DIN code, this is a very specific formulation, lemon flavored, right? And I know that it's that specific box because when I looked up this DIN number, it brought me to lemon flavored PDFer. I said, okay, if it was a different flavor, would be a different number. I don't know. But I do know that this product matches this DIN number. And oftentimes what will happen though is it's based off of the pharmacy, right? So if the pharmacy doesn't have these products, sometimes what they'll do is try to give you an equivalent. And if they don't have that, you say like, oh, we don't have that in stock. You could be like, okay, well, can you order that? And you just ask them to order it because they might not have the specific versions of, but like these are on the shelf, right? This is on the shelf. This is on the shelf. I think even this is on the shelf where you could just pick this up, but you might not have, the pharmacy might not have that particular brand, but that's okay. If you're open to waiting, you can ask the pharmacy to order this on your behalf and say, this is going to be covered, so make sure. Okay, so Palifer, which is really well tolerated. Also, FYI, I'm not like being paid by any of these drug companies like to advertise their brand. This is just specifically what NIHB has chosen to cover. Same with allergy. And I think a really big cost because Indigenous people often live in places that aren't ventilated very well. There's more pollutants that are going into the environment. Tons of kids with like allergies, asthma, which is essentially in response to allergens. And even if you didn't have allergies like before, and now all of a sudden you do, that's becoming more and more common because of currently what we breathe in the air. And so allergy medications are covered and they cost a lot. Like a box of Reactin like this, if you were to just go pick it up at Shoppers Pharmacy, would probably be $13 or $14. Maybe if it was on sale, you'd get it a bit cheaper. But Reactin, the actual name brand, is covered. Cetirizine is the medication name, right? So sometimes the pharmacy, they'll be like, oh, well, we can't give you Reactin. We can only give you cetirizine. They're the exact same thing, exact same medication. Sometimes people have a preference over brand over generic. They're like, well, the brand doesn't work for me or the generic doesn't work for me, which is okay. But just FYI, both formulations, Reactin and cetirizine, are covered. The 10 milligram tabs, even the 20 milligram tabs, right? This is like an extra strength one, but this is the specific DIN number for this. So this could be covered. Get a prescription from a provider, bring it to your pharmacy, make sure that it has the specific DIN number and that the prescription is for this particular type and it will be covered. Same with Benadryl, right? Benadryl allergy, children's Benadryl allergy liquid, right? These are like things that like people often need, when they're out and about. Arius, which is a type of allergy medication, and even EpiPens are covered. When you get a prescription, right? There's EpiPens for kids and adults, so we shouldn't be paying out of pocket for those. And my understanding is that there is not, we're going to look it up though, because let's see. Let's look on our Express Scripts and see if there is a limit on how often we can get it. So the chemical name would be epinephrine. Let's look it up. Okay, so adrenaline. I'm just going to bring this down here. EpiPen. Okay. So if I'm looking at this one right here, actually that's way too much. The EpiPen Junior, which is 0.5 milligrams. I view details and it tells me that it is an open benefit. And it doesn't say anywhere, hey, you can only get one per year or two per year. So theoretically, you could send a prescription for these things and they should be covered in the province of Ontario, Nova Scotia, Newfoundland, and Saskatchewan. Okay. But this is the way in which we have to confirm that drugs are actually covered, which is annoying, but it's how we do it. The other thing to consider for vaginal health, right? So people often get yeast infections. And so you're just like, okay, I'm going to go to Shoppers, I'm going to get Canestin. Well, that's actually covered by your status card if you have a status card. So if you get a prescription and it has this specific DIN number, you can get the 1% cream, the 2% cream. You could get this very box right here, the Comfort Tab external cream, and it comes with like inserts to go inside as well. Like, right, it comes with tabs and a cream, and there's different variations of that, and actually lots of different options. So this is covered. Get a prescription, get it to the pharmacy, make sure it has this DIN number, and get it covered. um, the other thing too is this estrogen vaginal cream. So oftentimes people have vulvovaginal atrophy. That's essentially when as you age and you have less estrogen in your body, the vulva, which is the outside of the vagina, it starts to become very thin. The skin becomes very thin, right? It's not like, thick tissue like it was maybe when you were younger, but the skin and even like your introitus, which is the hole, starts to get a little bit smaller, right? So things atrophy just means things getting smaller. And that's a really common thing in menopausal women because they have less estrogen, right? Estrogen is what keeps everything juicy and flowing. And so this is an example of a medication. Like if you have pain, touching the outside of the vagina, or you have pain during sex and you're becoming a bit older, know that that actually could be related to atrophy of that area. And estrogen cream, essentially estrone vaginal cream, is covered with a prescription and can be applied. And lots of estrogen vaginal cream doesn't have as many risk and side effect profiles. So we're like, what about breast cancer? And most estrogen creams just have a local effect. So even people who do have cancer that have estrogen receptors, they'd still be okay taking this. But that's just, if you're uncomfortable and you notice that it's like a little bit of blood when you wipe, or it's like really dry and it's really itchy in your vaginal area, this medication is actually covered. Same with parental support. So this is an example of a breast pump. So breast pumps for people is actually covered. It's a really annoying process, but it is covered and it is worth it. And I have gotten it successfully for people. So something to consider is that there's specific forms for different things, right? So if you wanted wound care, if you wanted, I don't know, like a hospital bed in your house, there's specific forms on the Indigenous Services Canada website. This is the one for an electronic breast pump. And so this is the specific DIN number that I would need to include. I would also need to include this form. So I, as the provider, you would come, book an appointment. I would say, hey, what's going on? You'd say, I would like a breast pump. I say, okay, yep, that's covered. Let me print this form and let me fill it out. Because it has different information, right? And you have to make sure you include the infant's date, whether you're going to be renting from the hospital or whether you're going to be buying your own electric breast pump. And then you need prior authorization and medical documentation, right? So essentially having a medical justification supporting the need for an electric breast pump, meaning like, maybe you have HIV. And so it's advised that when you have HIV and you don't know your viral load, that you hold off on breastfeeding because we don't know if that milk is contaminated. Okay, well, theoretically, could someone pump their breast milk uh, for you? Like you could get this, give it to them, and someone else who is currently breastfeeding. Yes, you can share breast milk, especially if you have like a lot of trust in people that are around you. And there's lots of different. Even if you were to Google like breast milk available in your region, you'd find lots of little local support groups. But sometimes breast pumps are needed because babies are premature and they have not a great latch, right? And so the only way that they can drink it is if it's from a bottle, but the parent still wants to breastfeed. And so there's different types of options, but this is an example of something that's covered. People wouldn't have to pay up front, but you would have to include this particular form, signed, dated, have all the indications with this DIN code, and then send it to a pharmacy. The pharmacy submits it on your behalf. They say yes or no. NIHB says yes or no. And they don't say yes or no to me, the physician, or you, the patient. They talk to the pharmacy. That's the people that they're confirming things with. So whenever you're like trying to get an update on like, hey, where's this medication? Um, Oftentimes it's not your provider that you need to talk to, it's your pharmacist and saying like, hey, where am I? Because they don't update me when something gets covered. They update the pharmacy that put in the request based off of the prescription that I wrote. So this is though like you can get an electric, have one rented, and yeah, or have a manual one. The different options are covered. Okay, so we have a question. Does NHB reimburse people who pay out of pocket for items that are covered? So this is kind of a hard question because not really. So say you were to be like, I don't want to wait until like I don't want to wait for this process. I want to just go buy and submit it. You could try. I've never seen that be successful because the issue is that when NHB has a particular process for something, they expect you to use this particular form, right? So I think, for example, if this prescription and this form wasn't sent before you bought the specific thing, then they're likely not going to pay for it. Some that could be different based off of the pharmacy you're going to, but oftentimes no. So like say I was pregnant, I wanted a breast pump. I'm like, whatever, I know it's covered. Let me just go buy it and I'll submit it. And they'll say no. Why? Because you need a prescription from a provider and you needed to fill out this form, and then this form needed to be submitted to NIHB, and the pharmacy that submitted it needed to give it to you. Even though what they might do is literally walk over to the aisle that has this and the same exact thing that you would have bought. And you're like, yeah, I literally could have done this. I could have just walked to the same exact aisle that you're walking to, grabbed it, and paid for it. But if it's not done through this process, it's unlikely to be covered. They technically, NHB doesn't have an obligation to cover it, even though it should be. Okay. There's also things like just other things that sometimes people don't think about in terms of like parental supports, like right nipple shields. So this is an example where breastfeeding, if you're or chest feeding, if you're having trouble with latching, or your nipples are really painful or sore, right? They're dry, achy, have infection or something like that, or you have inverted nipples, meaning the nipple is not on the outside, it's pushed internally. What you could do is create this, and it's a little kind of device that has small holes. So that way the baby can specifically latch onto this and create suction and then have breast milk come through this. But as no prior approval is required, which is nice, but there's a limit. So you can have 6 shields every 3 months, maximum coverage of 6 months. Right? So it's just very arbitrary number. I'm like, where did we come up with this number? 6 shield every 3 months. Like, well, what if you want to like wash them or reuse? Like, how would you, right? So it's just, again, NIHB is not intended for equitable services, but know that this is available and technically it's an option to you, despite the what's being covered being very bizarre and arbitrary and not making a lot of sense. Like if people truly needed this product the entire time they chest fed, they should just have access to it. Okay. An example that for folks that are quitting smoking. So even if you weren't going through non-insured health benefits, this is true of anyone within the province that has an Ontario health card or whatever health card. Your particular province will have some type of um, nicotine cessation or smoking cessation program where they have it where like a certain amount of it is covered for free. And so if you're an Indigenous person with a status card, you do have to go through status first, right? So you wouldn't get access to what people in the province would get to. You'd have to go through what is covered through non-insured health benefits, unless you just said, no, I don't have a status card, right? You could just tell them that, even theoretically though, even if you did, but these are some products, for example, that are covered. So one of them being Nicorette gum, right? And Nicorette is often a brand that's used, but I just want to point out to people that there are other options that are covered for gum for people to try that aren't just the Nicorette brand, like Actavis, right? This product is this very specific DIN number, right? 800-15240. If you were to Google that and look it up, this is exactly what comes up. So theoretically, if your provider wrote a prescription and said, I only want this particular Nicorette gum, the pharmacy didn't have that, they'd have to order it for you. They did have it, they could give it to you, but this is an example, like, I didn't know this, but nicotine gum coated with whitening, like, and that there's different flavors, right? Like, so there's, I didn't even really know that this was an option because you'd have to specifically go into that Express Scripts, type in nicotine, and then see what's covered. But this DIN number covers this product. Then this DIN number covers this product, and this one covers this product. So options like include the gum, include the patch, things like the quick mist or like the Vapo kind of inhaler. But the thing is that there's limits to this. So the gum, it's usually 945 pieces during one period, right? If you're, you go through that pretty quick if you're taking gum even 4 or 5 times a day. But the year, so because it's over a 12-month period, the year starts on the date that the first prescription is filled. So maybe I wrote your prescription, it was 3 months ago. The 3 months doesn't start when the prescription was written. It starts when the prescription was given to the patient. So from that point on, right, they'll give you supply until you're past the 940 very specific pieces of nicotine gum or lozenges or however long it's been. And then at that point, once that quantity has been reached, it's definitely possible to be re-eligible, even if like it's still within, like, you've gone through it and it hasn't been a full year yet, especially, but you'd have to make a case for it, right? Why do you get to have gum more than other people? And I would say, well, because of this, this, and this. But again, a bit ridiculous for something that when people are trying to take care of it. Quitting smoking is probably one of the best things you can do for your health, just generally, in terms of morbidity and mortality. And so just even like 940 pieces of gum, like this is absurd. But this option is available. This option of it is available. And if you were to look, you can see that there's other things that are covered. But the issue is that you only get to pick one at a time. So say you like the gum and you want to do the patch as well. Oftentimes what will happen is that you have to pick and choose, right? What is the as needed nicotine replacement therapy? So you'd have to pick between gum, lozenge, or inhaler. And you could also have a medication like Zyban or Champex, which are actual prescription medications that people take. But yeah, you'd have to pick between them. So say you started a bit of the gum, you got like 2 months worth. You're like, no, I don't like this. I'm going to try the patch. Okay, so then that's 2 months out of the 12 months that you're allotted. So you could that's why when you're given prescriptions for nicotine products, don't just like walk away with like 7 boxes. Don't walk away with the full 940 pieces of gum, because especially if you don't know if this is what you like, right? Because you can't have more than one. So you can't, even if another provider wrote you another prescription, they say, hey, nicotine replacement, they would do the prior of this, the prior approval, and they'd say, no, this person's only eligible for this. And so try not to take large quantities especially when you're not sure which product is going to go good for you, because you want the flexibility to change. If they've given you 940, that's it. Even if you don't like the gum, like you're not really eligible for anything else after that. So just kind of before committing, figure out which product works for you. This is specific to trans and people in the LGBTQ community, because here at ONWA, we think it's very important for people to feel safe and like their authentic selves. And so this could include things like hormone therapy, surgeries, ID changes, but it also includes things like upper body and lower body garments or things, I guess I should, like bra inserts or compression, things that help affirm your gender identity. So this is actually something I think that's cool that NIHB did, and I was very impressed that they included this, because it's really helpful. And so I'm thankful for the people that were external to NIHB that advocated for this. But for example, if you were an individual where you wanted to have it where your chest looked larger, so padding, bra inserts, right? You could technically, no prior approval is required, and you could get one every 2 years, 3 per year, right? So again, these aren't really huge quantities of that. Same with for a compression or chest binder. So theoretically, these things are covered, right? Compression shorts, which is like when you're trying to, so there's not a bulge, right? You're trying to like make things appear flat. Even a stand to pee device, right? If that's a part of your gender identity and feeling like your authentic self is that you want, instead of sitting to pee, you want to be able to stand to pee. Technically, you could get a urination aid. These are the people that could prescribe it: a medical doctor, a nurse practitioner, or a psychologist. Provider, general, prior approval, no, you could get one per year. Same with like packer or phallus, which is like a penis that's made with the different materials that you could put within your underwear. Dilator kits, right? So one every 5 years. Okay, well, that's not very realistic, but I've yet to find a place, at least here in Thunder Bay or in Northwestern Ontario, that where if I were to create this prescription, great, I can include this DIN code and I could put this very specific thing on the prescription, but I actually don't know where people are going to fill this. So if you in your region know of places, please put them in the chat so that we can let other people know. But I, as a provider, have yet to find somewhere where I can send this prescription for people to actually get access to these things. Because again, like, this is nice that it's covered, but the places where you buy these things are often like sex shops or things like that. And sex shops don't have pharmacies built within them. So how do we send a prescription like this so that it's covered? And I don't know how much of it's covered, right? Because it has to be a specific price that they don't list. So I don't know. Say your compression shorts that you wanted were like, I don't know, $60, but NIHB covered 40. There's no way for me to look at additional details of how the dollar amount that's covered. We would simply just have to submit and hope that it was within the range that NIHB will actually cover. And this is the difficult part and the bureaucratic part that makes it really difficult is you can see the DIN number, what's covered, but the dollar amount, well, how much can I spend for a packer? Well, how much can I spend on bra inserts or chest binder? And the issues that we don't know. And NHB really just like gatekeeps this knowledge because I would like to know, but I don't have access to that, and neither would you. Neither would the pharmacist. Really, it's not until it gets sent, and then they send it back. Okay, so that's the extent of things that I wanted to make sure that we went over to let you know of things that are covered and prescribed. So what we'll do is I'm just going to go back. We're going to go back to this website, Express Scripts, so that I can show folks, answer some of people's questions here, because there's questions about if this is covered, and I actually don't know. I'm going to have to look it up. So let's do the whole screen. We will share it. Okay. And so this is full screen. So let's see here. There's a question about Vitalux. I don't know if that's covered. Let's look. Okay, so item name. So there's someone who is concerned for macular disease. And of course, yeah, there's different vitamins and stuff that people will recommend, which has a lot of good evidence actually, but I don't know if it's covered. I'm going to look it up. 1 second here. Supplements, okay. What's the chemical name for Vitalux? I know it has different vitamins within it. It wouldn't be under chemical name. It doesn't show up. No records found. What about Vitalux? Nope, doesn't appear to be covered. Let's see, because sometimes if there's, but it has a bunch of things in it. So I don't know that there's a specific, because sometimes if you type in the chemical name, then sometimes you can get access to it, but I don't actually think there is a chemical name because it's like a mix of like vitamin C, vitamin E, zinc, copper. So theoretically, could you get all of the ingredients that are in Vitalux? I don't even know if zinc is covered. Like, this is the thing. And sometimes what I'll do is I'll play around with this and be like, okay, if I can't get a specific, tab that I want, can I take out some of the ingredients then? And then combine those. I mean, you'd be taking a lot of medications, but theoretically, if Vitalux has how much, depending on how much copper they have, like we could put these things together and you could just take a bunch of them, of the, the vitamin C and all of that, and then kind of put it together. But again, you'd have to be matching it up. Okay. I don't see any other more questions. Something that I want to point out to people too, if you're like, well, how do I figure out medical supplies? Because things like wound care are actually covered, but the issue is you have to submit a form that talks about the specific wound that you have. So say I wanted to, I'm going to go back here, show you how to do this. Okay. I'm in Express Scripts. I don't want to be on pharmacy anymore, but I do want to look up medical supplies and equipment. So this is actually, sorry, that's if I want to become a provider, which I do not want to own a business that does that. So I'm going to, also sometimes it says client, but you have access to provider information too. So I don't really know why it's like laid out that way. But let's see here. Ooh, price files. Let's look at this. Medical supplies price file. Again, and this is the thing, you wouldn't know unless you had access to the, and so I didn't actually realize there was specific access here. So this is good to know. Okay, so for example, a hearing device, hearing aids, if it was completely in canal or invisible in canal, a fixed price of $575. Okay, so technically, if we remember how to do that, we could look at the very specific things that you want and see how much of it they would cover. Which the only way that might be helpful for people is if you are wanting to like look at a pharmacy, like you want to pre-scout a pharmacy of where you want to potentially bring this prescription. Maybe it's like a specific, I don't know, ear audiology place, right? And you want to go to, you could kind of know ahead of time, okay, how much are they going to cover? So, oh, and type 3 is the maximum. Okay, so this is the most that you could spend on a hearing assessment. Type 1 means is that it's a benchmark price. So like approximately for this adhesive white for this hearing device, this is the baseline price and there's no maximum that's set, which is kind of, it's probably good when there's no maximum set, because then that means if things are more expensive than they need to be, you can at least get it covered. Okay, but let's see here. So non-insured health benefits, I want to go to their website, right? This is First Nations Health Authority. So this is BC, who owns their, who distributes their own funds. Benefits and services. Again, it's not intuitive to move around in this, and even I sometimes struggle to figure out what is actually covered. So I'm trying to show people here. So maybe you want to know about footwear. Okay, so we go to that particular section. These are the policies. Who could write a prescription? A chiropodist. If you're in Ontario, Saskatchewan, or New Brunswick, a podiatrist, a nurse practitioner, or a physician. So things, for example, like orthotics, actually everyone is eligible for orthotics if you have a status card. But what you'd have to do is the footwear prior approval form, right? Which is under this list of things. So let's see here. Limb and lower body, pressure device, self-care, electric breast pump. Because some things have forms and some don't. And there's no intuitive way to know this outside of just looking. I will try here, footwear. See what it entails for us to do. Okay, so you have to add, okay, palliative care, client is in a healthcare facility. Oh, interesting, urgent. So does this mean you can only get this particular item if you're in a palliative care unit or health facility? That doesn't make any sense. Eligible claim, program verification. But again, so we need to know the very specific item, the DIN, the markup, right? And this is the part that the pharmacy fills out. You don't have to fill that part out, but someone has to fill this. Someone has to sign saying, yes, this is how we did this, and this is what needs to be included, right? So custom made shoes or foot orthotic benefits, photograph of feet preferred. Like, so this is like if you were to go to a specific place that they would do this, right? I wouldn't submit this and you wouldn't either. Um, but this isn't, yeah, this is just a ridiculous form. Client living, diagnosis, reason for request. But what I want to know is, do I actually, and for medical supplies, sorry, that's not on this, right? So if I tried to like look up, okay, can I look up like wheelchair, for example? It's not going to show up on this particular type of search. You have to actually go to their website under these lists and figure it out from there. Okay. Do we have any more questions? I'm gonna stop share. Okay. So in summary, um, lots of everything within healthcare um, is your treaty right. And how we know is because NIHB covers it. That's how you win. So when I say treaty right, I'm talking kind of like on a broad scale of like, so where is your treaty right? Well, the signed documents that are housed within Canada. Like, I'm not sure specifically where to find those things, but healthcare generally is your universal healthcare is your right as someone that lives within Canada, but especially also your right as an Indigenous person and things being covered. And most things can be covered. So my suggestions to you are to really try and always have the NIHB formulary ready to go, right? So that you, when you go to the pharmacy, you anticipate that there's going to be problems because you can physically scroll, hand it, say, look at my phone. It says right there. And then they'll put that DIN number in and it'll go through and then they'll stop being rude and annoyed with you, right? Because you'll show them the physical product. The other is checking. If before you're about to buy something, especially if it's not urgent, right? And you're like, well, I could use this Gravol, but I don't need it this very second. Get a prescription. Go and get a prescription and fill it and have it available. I think there was a question in the chat about what could allies do to help, and I think the biggest thing is really lobbying healthcare providers to to put in the work of like put the DIN number in, call the pharmacy, and obviously just advocating for people's self-determination, right? And Native people, like if I was in charge of, I would just, everything would be covered. I'm like, why wouldn't it be? This makes no sense that this isn't covered or there's really, really strict criteria or that there has to be a form, right? Just give people the things that they need. Because that's what self-determination is you deciding. So I would say, yeah, to lobby government to always encourage and support anything where Native people get to decide what they want, right? And then, going with people to a pharmacy if they're concerned that something's not going to be covered, going with them, and you'll have the list, right? And saying like, look at the list, I have it. I guess yeah, those would be the main things. Okay. Let's see here. Okay. I had a pelvic floor reconstruction and hysterectomy. My doctor recommends pelvic floor physio. Can't find anywhere to get it covered, and I'm on unemployment. Yeah, unfortunately, pelvic floor, any type of physiotherapy that's private, which almost all pelvic floor physiotherapy is private, will not be covered by NIHB. So the only way to get that covered is if you again had like private benefits through work, and of course you being on unemployment you wouldn't have access. So that's a really difficult situation to be in because NIHB won't cover it, even though everyone should have pelvic floor after they pelvic floor physiotherapy after they have had any type of surgery or any vaginal delivery. What I will let you know is in the meantime, because sometimes what happens when I can't specifically get access to physiotherapy for patients, this is what I'll do. And it's not as good, but I'll literally go to YouTube and there's a very specific channel. Because a lot of pelvic floor physiotherapy, it's helpful if someone's there, but theoretically you could watch someone do it. So this is when I'm like, when I can't get physiotherapy for someone, I'll go to YouTube and then I'll type in pelvic floor physiotherapy. But I'll show you. There's a really credible physiotherapy channel. I just can't remember what it's called. Pelvic floor exercises. Okay. Yeah. So like for beginners, it is Healthline. Nope, that's not it. Mm, okay. It's not on this list. Um, Physiotherapy. But this is what I would recommend so that you can at least get started with something. Oh, I think it's NHS. Yes. So this is like the UK, right? This is like their healthcare system, similar to how we have it, but this is an example of when you're trying to access specific physiotherapy recommendations. I because this is medical providers that have contributed to this. I personally like this. It has other health conditions, but lots of physiotherapy is available through this particular YouTube channel. There's also the physio channel, Mayo Clinic, right? Those are examples of ways that you could try and do specific types of movement. So yeah, that's what I would do because yeah, you're in a really hard position because it's not going to be covered by NIHB, and it never is covered by NIHB. Okay. So orthotics are only covered if I'm in an emergency situation. I'm going to confirm that for you because my understanding is that any Indigenous person can get orthotics, and you don't have to be in an emergency situation. So just let me confirm that. So that was a weird form that I didn't understand. So medical supplies and equipment, mobility, maybe? Limb body orthotics. That's probably I was looking under the wrong thing. Mm, I'll look into this while we move through this, but Carly, I'll hand it over to you just to talk about the survey in the meantime while I try and look this up.
Okay, thanks so much. Um, so I'm going to ask Jordis or CJ just to post the link. You probably already have done it. So, but just to post that link for that survey. It's just a very short, I don't even think it might be 10 questions, just a few little bits of information for us. But one of the most important ones on there is asking you for what your requests and what your wants and needs are for health information. And so I wanted to let you know that we go through every one of these surveys that you've all sent in to us over what's probably at least a year and a half now that Alexa's been doing these monthly health talks. And we will look at all of the answers that you give us, especially that information, that feedback that you provide to us, asking us for topics, future topics that you're interested in. So we thank you for all that information that you've provided to us. And if anybody who does fill out that survey for us, and you would love your name to be put into a draw for our health basket bundle for this month's talk. Just one of the very last questions is just asking for your email or for your name. And so just a way that we can get a hold of you and we can put your name in that draw, and we'll let you know right away once if we pull your name. So thanks everybody for filling out those surveys. And Alexa is looking up something else here.
Yeah, this is for the orthotics question because someone asked, like, "Oh, is it covered
Such a good
only in
question.
um, so custom made foot orthotics. So it says here, this is the item code. I don't, even if I were to prescribe you orthotics, I don't it's chiropodists or podiatrists are the people that actually take foot measurements. We don't know how to do that. So, but it says prior approval required for a custom pair of foot orthotics is no. So that means if you were to go somewhere that created orthotics, right? You could Google purchase orthotics, or NIHB provider for orthotics. It says one every 2 years. Clinicians should choose the correct thickness or durometer for the client's body weight, right? Because they want it to last you for 2 years. Oftentimes it doesn't. And there's even a specific like note here about if it needs to be replaced, that you'd have to, it's considered on a case by case basis. But this prior approval required, no for this, but if you wanted like a foot orthotic custom made left, just a left one or just a right one, like say one foot is pronated and the other is supinated, like and you didn't need a pair, I guess then you do need prior approval. That means that you would do that specific form that I was talking about. But for this, if you went to a place that was able to direct bill to non-insured health benefits, you could go to a place where there's a podiatrist or a chiropodist, or some chiropractors even do that. That's an instance where maybe an adjustment from a chiropractor isn't covered, but if they direct bill and are someone that can make you orthotics, like do a cast of your foot, then it would be covered. So that means they could send a prescription. Yeah. Okay. I think that's everything. Okay, wait, sorry, there's more questions. Okay, that's okay. Open benefit means no prior approval, but who has the ability to prescribe? No family doctor, NERX, require trip to emergency, something simple like ibuprofen. That's a really great question because it can only be from very specific individuals. So you're right, family doctors and nurse practitioners, it isn't really readily available. So then those really are the only people that could prescribe it, right? Every thing that we look up, it has the specifics of who could prescribe it. So like ibuprofen. So say we wanted ibuprofen and we wanted the specific brand, great. Um, Okay, so it's an open benefit, meaning you don't need prior approval. So people who have a license, so for sure, medical doctors and nurse practitioners. But yeah, if you don't have access to that, you're kind of crap out of luck. Outside of like midwives can prescribe certain medications, and there was this thing about pharmacists being able, pharmacists prescribing for certain things like ear infections and things like this. So I'll pull that up, but not every pharmacy does that. So sometimes you'll show up and be like, "Hey, Plan B is supposed to be covered. I don't have a prescription. I'm not able to go see my doctor. Can you do it for me?" And so that particular pharmacist at that particular pharmacy actually has to be registered with NIHB in order to do that, because not every pharmacy has a pharmacist that's willing to give a prescription for something. So that's why sometimes you're like, but it says online that pharmacists can prescribe X, Y, and Z, and that's only true if the pharmacy participates in it. Let's see here for comp. So what can they prescribe? I'm just thinking like, could you just go to the pharmacy and get something without having to do that? And it looks like you could. Contact your local pharmacy for details. Yeah, and so then it pulls you to Health 811. So what I would do is, and what I do for myself is I call pretty well every pharmacy and ask, is there someone that could prescribe this for me without a physician, nurse practitioner, or midwife prescription? And they'll tell you. And that's essentially the way to go about it. But theoretically, yeah, it has to be someone that can actually write a prescription. It doesn't look like this is covered. Well, first you'd have to call the pharmacy and actually even see if they have someone that does any of these things, let alone something like ibuprofen. But I assume so, especially for like menstrual cramps, you'd probably be given ibuprofen for that. So I assume that they could provide that. But again, it's pharmacy. So not every pharmacy has the ability to do this, because you need a pharmacist that's willing to do it. Mm, How about emergency supports when you need to resort to other programs? Can it be relayed by Jordan's principal claims as emergency when NIHB is slow or needs documentation? Yeah, so something to consider is that Jordan's principle is a lot quicker, and oftentimes pharmacies will do it even without the provider knowing, right? Like there's times where I'm like, oh, I want to make sure this gets covered. And then I look back and I'm like, oh, Jordan's principle covers it. So the issue is now Jordan's principle, though, is getting backlogged with things that NHB should be covering, right? Because Jordan's principle money comes from a different budget. So it really sucks when like the specific things that we need, that we know NHB covers, but then, yeah, if you needed an emergency situation, the pharmacist is usually pretty good about contacting Jordan's principal on your behalf. So there's times where like I'm like, wow, you got that really quick, and they said, yeah, I went through that. Um, so yeah, in emergency situations, that's what I would advise: is ask your pharmacist to submit it specifically to that. Mhm. Otherwise, Jordan's principle, I'm not really good at submitting that kind of stuff. The only times I've done that, like in order to, you'd have to actually Google Jordan's principal office within your area, because every region has a specific phone number, and then just call. Be like, hey, I need this covered. Hey, I need this thing. And they'll advise you. But as a physician, I have no idea how to submit Jordan's principal um, claims, because I often don't do it. It's usually because Jordan's principle is usually for things like kids need like speech language pathology, or they need a dehumidifier for their room, right? Things that like are not a medication. Okay. Anything else? Okay. Well, thanks so much, folks. Fill out the survey. Hopefully, this was helpful. If you have more questions, feel free to reach out to the team or comment, and we can try and get through those. But otherwise, it seems like it. That's it.
Thank you so much, Alexa. I just wanted to say that there seemed to be some problems for some people just accessing the survey. So we've just made some changes and resubmitted or resending out a survey link, hoping that it solves those problems for anybody that had some issues. So I think we will just I'm just going to talk to Jordis here and just make sure that we resolve that problem before we go offline. Thank you so much though for sharing all that information. I really liked how you even had some suggestions for just ways to prepare and information to always sort of have at the ready um, to help those providers and in order for you to get everybody to get what they need. Um, I also was just going to ask if Jordis or CJ could post a link for the Mid Des Moines Health Clinic. I was thinking about if anybody had any difficulties and they wanted to speak to somebody, that we have a health systems navigator at the Mid Des Moines Health Clinic that would be all too happy to help out anybody for any questions or any what's the word, any barriers or any problems that have arisen for them. So and that phone number is 807 697 1753. But I believe that Jordis or CJ has been posting up that link as well. So thank you so much to everybody.
I just posted the Mid Des Moines thing, but the survey is still broken.
Okay, I'm so sorry, you guys. We will.
We could close the live and we'll do a post on social as a follow-up with the survey link.
Thank you so much.
Okay. Bye, folks.
Bye, everybody. Thank you so much for joining us. And thanks